That's an excellent question. We should look at elderly patients beyond just age. It's very critical to evaluate patients who are older using comprehensive geriatric assessment because we recognize that age by itself is not what defines elderly. We have to look at performance tests, but performance tests by itself is not sufficient. Elderly patients have many other issues that should be factored in making decision regarding therapy, such as the number of medications they take, comorbidities that could range from hypertension, diabetes to heart disease. All of this could impact the selection of treatments in hematologic malignancies. But also, most importantly, when we prescribe certain regimens to the elderly population, we have to look at beyond the regimen we're prescribing. Adherence and compliance, very critical. We have to make sure that elderly patients are able to adhere to these medications. Are there any situations where the doses are being reduced because patients are not, the elderly are not able to tolerate the regimens as much? And how this really, dose reductions affecting the outcomes of these patients? Are there any needs for dose delays because of toxicities? And I will say this, that while we focus on clinical trials, on grade 3 and 4 toxicities, we need to remember a couple of critical points. One, the lower grades of toxicities, grade 2 for example, could have more impact on elderly patients, could affect their quality of life. Maybe a grade 2 toxicity might not affect a 35-year-old patient being treated for hematologic malignancy, but that might not be the same in somebody who is older. The second thing I would say is clinical trials have historically enrolled younger patients by default. So the elderly population is underrepresented in clinical trials, and that really takes me to, it underscores the importance of real-world evidence for elderly patients and monitor them in the real world to understand what happens, so this could impact how we manage these patients. I know I didn't address any particular hematologic malignancies, but in my mind these are the principles as we actually attempt to manage elderly patients with any hematologic malignancy.